Today, we break down a major multi-center study, VentiBrain, published in Intensive Care Medicine, 2025, exploring how ventilator strategies impact outcomes in acute brain injury, (ABI) patients. Most evidence for lung protective ventilation, LPV, comes from ARDS trials, but ABI patients were largely excluded due to fears of worsening intracranial pressure. Guidelines are vague, and global practice is inconsistent. To describe current ventilator settings in ABI patients and evaluate if these settings are associated with ICU or long-term mortality and neurological outcomes. Study type: international, prospective, multi-center, observational cohort study conducted across 74 ICUs in 26 countries. Population: 2095 adult patients with acute brain injury, TBI, IC, SAH, ICE, requiring invasive mechanical ventilation. Data collection: ventilator settings recorded daily for the first 7 days and on days 10 and 14. Parameters included tidal volume, plateau pressure, PEEP, driving pressure, FIO, POW, FIO, compliance, and ICP. Statistical tools: linear mixed effects models for between-country variability, time-dependent Cox regression for mortality association, logistic regression for neurological outcomes, adjustments for age, sex, type of brain injury, GCS motor, POW, FIO, pupillary reactivity. Ventilator settings: median TV, PBW, 6.5 ml per kilogram, Pplat, 15 cm hydrogen oxide, driving pressure, 9 cm hydrogen oxide, PEEP, 5 cm hydrogen oxide. Lung protective strategy was used at least once in 91.6% of patients. Variability: marked differences in ventilator settings across countries, especially mechanical power and driving pressure. ICP: 22.7% had at least one episode of ICP greater than 20 mm of mercury. Despite this, no adjustments in ventilator settings were made. Mortality: ICU mortality, 29.2%. 6-month mortality, 42%. Higher Pplat, Ppeak, and driving pressure were significantly associated with increased mortality. A U-shaped relationship was seen for PEEP, RR, and FIO. Strengths are large, diverse cohort and rigorous stats. Limitations are observational design, daily, not continuous, vent data which lacks granularity. So, does this change practice? Yes, partially. It supports lung protective ventilation here. Pplat and driving pressure must be monitored closely. FIO and PEEP need careful titration.